from the internal acoustic meatus up to the first genome. That is, the meatal as well as the labyrinthine part get involved in fractures of the temporal bone. Okay. What are the types of fracture of temporal bone? What are the types? There are two types of fractures of temporal bone. And if I draw a skull base, okay, anterior cranial fossa, middle cranial fossa, and this is your foramen magnum. And almost here comes the temporal petrous bone. Okay. External auditory canal. Right. So this is your petrous part of petrous bone, right? So there are two types of temporal bone fractures: longitudinal fractures and transverse, right? So in a transverse fracture means the fracture line runs perpendicular to the long axis of petrous temporal bone. This is a petrous temporal bone, and this transverse fractures, they run perpendicular to this is a long axis, so this runs from the middle cranial fossa, it runs perpendicular to the long axis of the petrous part of temporal bone, and it reaches up to the foramen magnum. This is the anterior cranial fossa, middle and the middle cranial fossa. So from the middle cranial fossa goes is the transverse fractures, and the longitudinal fractures, they run parallel to the long axis of petrous part of temporal bone. It will be almost like this. So usually this longitudinal fractures constitute around 80% of the fractures of temporal bone. How this fracture temporal bone happens? It happens in road traffic accidents. Okay. So 80% of the fractures are of the longitudinal fractures. It starts from the roof of the external auditory canal. It goes through the middle ear, and the line is parallel to the long axis of petrous part of temporal bone, right? And it is parallel, and it reaches up to the foramen ovale of the middle cranial fossa. So that is longitudinal. So in which type of fracture there will be sudden transection of the facial nerve? Sudden transection, obvious, it occurs in transverse fractures. Okay. So in transverse fractures, usually this part is involved. So which all nerves will be affected? The facial nerve proper, as well as the nervus intermedius, and also 7th and 8th nerve will be along with the 8th nerve, vestibulocochlear, right? 7th and 8th. So what will be the complaints of the patient? If there is a sudden cut, there will be facial motor weakness along with the vestibular component. What will be the effect? There will be giddiness. Cochlear component, there will be sensory neural hearing loss, right? But in a longitudinal fracture, what happens? This area will be involved. So it will be more of a conductive type of hearing loss, right? And also sudden facial nerve palsy will not happen. There will be traction. There will be traction on the facial nerve. So slow traction. So there will be delayed facial nerve palsy. And 8th nerve is not involved, usually in a longitudinal fractures. So in whatever may be the cause, if the patient after sustaining a head injury, it may not be conscious enough to complain of a giddiness or hearing loss. So one sign is particular importance in case of a fracture of temporal bone. And what is that? It is the battle sign. Battle sign. What is that? Battle sign as a word means, many of you will think that it is due to battling or a forceful pressure of some area, trauma to some area. But actually it is a sign described by Dr. William Henry Battle in 1800s, and that is bruising over the mastoid area, this part. On this part there will be bruising over the lateral surface of the mastoid. There will be ecchymosis, or the bruising will be seen, reddish color, discoloration, and that is the battle sign. Even if the patient is unconscious, if you are seeing a battle sign, think in terms of a fracture of temporal bone or a skull base fracture, and go for an immediate CT scan of the skull base or along with the temporal bone. If you need more evaluation, an MRI scan can also be done. Okay, that is the importance of this battles. Labyrinthine segment includes the geniculate ganglion also, and the geniculate ganglion is a relay station for taste sensation from the anterior two-third of tongue, and also pain, touch and temperature from the root of neck, root of pinna and the posterior superior aspect of the external auditory canal, right? And in 15% of the cases, 15%, this geniculate ganglion, the bone over the geniculate ganglion will be dehiscent. Usually it is covered in the facial canal. In 15% of the temporal bones, there is dehiscence at the level of the geniculate ganglion, so that it will be more vulnerable to injury during surgeries. Okay. Then, from the geniculate ganglion, it turns a sharp turn, right? So, there is another landmark sitting there. What is that? Here, hook-like structure, that is processus cochleariformis. So, this segment from here to here is the tympanic segment. So, just anterior to the tympanic segment, there is processus cochleariformis. This is a landmark. This is a constant landmark, and this landmark is very much resistant to erosion. So even if there is bone erosion due to granulation tissue or a cholesteatoma, this processus cochleariformis will not be affected. So this acts as a constant landmark for the geniculate ganglion and also the tympanic segment of the facial nerve. Okay, 4 mm. This part is 8 to 11 mm. Okay, and here this part of the bone over this part of the fallopian canal is easily fractured. It's very thin and it is easily fractured. So chance of injury of this tympanic part of facial nerve is very common. Another one is that there is chance of bone dehiscence. One, that the bone is very thin, and second, there is chance of dehiscence of the facial canal. So that what happens? What comes here? Here is the oval window. So if there is a dehiscence, this bone will protrude out, right? There is no bone over that. This facial nerve will be exposed and it can prolapse down. If it is here, what happens? It can prolapse down. It can come here, this part. So it can lie over the oval window, or it can lie over the footplate of stapes. So there is chance of injury during what is the surgery done over the footplate of stapes? It is a stapedectomy or stepidotomy. So if there is prolapse of the facial nerve due to dehiscence of the facial canal, there is high chance of injury to the facial nerve during surgery. Okay. What is this segment? This segment is called the vertical segment or the mastoid segment, and it is around 12 to 14. So which is the longest of all the three? It is the mastoid part. It is 12 to 14 mm in length. What are the landmarks here? One is a pyramid, right? This is a pyramid, and the facial nerve always lie lateral to the pyramid. When from the pyramid goes what? From the pyramid goes the stapedial muscle. Okay. Where is it is attached? The stapedial muscle is attached to posterior crura and posterior part of the neck of stapes. And this facial nerve is lateral to the pyramid. Okay. One more landmark is the short pros of incus. Facial nerve is medial to the short pros of incus, or in other words, the short pros of incus is always lateral to the facial nerve. Facial nerve is always lateral to the pyramid, and the short pros of incus is always lateral to the facial nerve. Okay. Another one important landmark is the tympanomastoid suture line. Okay. Here comes a tympanomastoid suture line from anterior to posterior. First is the tympanomastoid suture line. Behind that comes the chordae tympani, and posterior to that comes the facial nerve. Okay, or the seventh nerve. Right? This is very important landmark during identification of facial nerve in parotid surgeries. So first is the tympanomastoid suture line, and just posterior to that is the chordae tympani, and the facial nerve is again posterior to the chordae tympani nerve. Right? And anatomical variation that happened here is there is a pronounced facial hump, posterior humping. In some cases, the facial nerve will go more posteriorly in the posterior wall, so that there is chance of injury during the mastoid exploration surgeries. And sometimes, instead of coming as one, this can go as two canals or three canals. Instead of going down as a single canal, it can go 2 or 3 in number. It can multiply. Okay, there can be 2 or 3 canals will be there. That is also another anatomical variation. And extracranial part. What is that? After exiting from the stylomastoid foramen, it is the extracranial part. What all things that can happen here? You know that the tip of mastoid start developing, or the mastoid process start developing from 2 years of age. So in newborn and in children less than 2 years of age, there is no mastoid process, and there is no mastoid process. So what happened? This stylomastoid foramen will be lie directly under the subcutaneous tissue and below the skin. Okay, stylomastoid foramen will lie directly under the skin and the subcutaneous tissue. So that what happened? If you put a postoral, usual postoral, how will you put a postoral incision? If this is your mastoid and you put the incision from the highest attachment of the pinna to the tip of mastoid. This is a usual postoral incision. In children what happens? There is no mastoid prominence. So what happened? The facial nerve will emerge directly from the stylomastoid foramen, and it will be just underneath the skin and subcutaneous tissue. So if you put a incision like this, what will happen? It can injure the facial nerve. So in newborn and in children less than 2 years, we put a modified postoral incision. How? It will be more horizontal. Actually, what you do is, you have to keep your finger here and then you put the incision. So that facial nerve is kept under safety. Under safe custody you put it. You keep a finger over that, then you put the horizontal incision. Right? That is in newborn and in infant children up to 2 years of age. Okay, Topo diagnostic test of facial nerve, even though it is of limited value nowadays, can be asked in exams. So, Topo diagnostic test. What is that? What is this topographic mapping? You must have heard that. That is, it is mapping a physical area, that is a 3D dimension into a 2D dimension, into a map. like that, in a topodiagnostic evaluation, that refers to testing an individual facial nerve branch. We are testing an individual facial nerve branch, each branches, so that we can get an idea about the location of the level of dysfunction or injury, right? In topodiagnostic test, we are testing individual facial nerve branch, and that the basic principle is that if there is an injury below the level of lesion, then the part above that will be spared, right? Like for an example, if there is a greater petrosal nerve will be spared in injuries below the level of geniculate ganglion, right? So actually there are 4 topodiagnostic tests, but the central lesions can also be diagnosed by certain investigations. So coming to the cause of facial nerve, first it starts from the cerebral cortex, okay, that is the supranuclear part. This is the face area. Then from there it comes, so this is the supranuclear, then your nuclear area, isn't it? Okay. These are pons. So this facial nerve fibers will come from here, located in nucleus, isn't it? Along with the facial nerve, what is the nucleus located, which nucleus is located in pons? That is the 6th one. 6. And from there it comes out of the, so this is the nucleus, and then exit is at the CP angle along with the 5, 8 and 7, right? Isn't it? 5th one, 7th and 8th vestibular cochlear. So that much is the CP angle, and from there it goes to which canal? It goes to the internal auditory canal, isn't it? These two. So the 7 and 8. 8 has got 2 divisions. What are they? The vestibular part and the cochlear part. And the 7. After that, where will it go? 7 will go into the fallopian canal, right? From there it go to the fallopian canal, and what is the dilatation there? There is a geniculate ganglion, and from the level of geniculate ganglion, which nerve goes out? Goes the greater petrosal nerve. So facial nerve comes, right? Then this tympanomastoid segment. From there, which all branches are given? From the tympanomastoid region goes the nerve to stapedius, isn't it? So this will be your stapedius tendon, stapes muscle, stapes op, right? Then it is coming down and going as chordae tympani nerve, where to the tongue and to submandibular and sublingual salivary glands, tongue and salivary gland. Okay, this will go to lacrimal gland, isn't it? Okay, then what happens? Oh, then the canal comes out. Coming out, and okay, so this is a course. From here, what are the topodiagnostic tests we can do? The greater petrosal nerve is tested by doing the tear test or the schirmer test. schirmer. And what is the test? We are putting a sterile filter paper into the lower conjunctival fornix. And there is commercially available Schirmer's filter paper strips are available. It is number 41 Wattman strip. Wattman strip. Okay. And it is a filter paper strip of around 5 mm wide and 35 mm long. There is a marking at 5 mm from here. We can fold at that mark. Okay. So it is put like this, 5 mm, and here it is 30. Altogether it is 35. So 5 into 35 mm. Filter paper strip number 41 Wattman strip folded at 5 mm from one end, and it is put into the lower conjunctival fornix. Where into the lower conjunctival fornix? Of both eyes you have to, right? At the junction of outer and the middle, here. At the junction of outer 1/3 and the middle 1/3, and after 5 minutes. Okay, after 5 minutes, measure the length of the wetted portion. Okay, so our filter paper strips are put into the lower conjunctival fornix and ask the patient to close his eyes. Not forcefully, but just close the eyelid and measure the wetted portion after 5 minutes. In unilateral cases, if there is a reduction of more than 75% of the opposite side, then it is taken as abnormal. And in some Bell's palsy, there will be bilateral reduction in the tear production. Then what will you do? Then take the length of the wetted portion of both eye, add them, and if it is less than 25 mm, it is taken as abnormal. Okay, you take the length of wetted portion of both sides and the sum of them. The sum of the wetted portion of both sides, if it is less than 25 mm, it is taken as abnormal. So if it is Schirmer test is negative, that means lateral petrosal nerve is normal and the lesion is somewhere below the geniculate ganglion. So that is about Schirmer's test. And another one is, what is the other nerve? Nerve to stapedius. So what we have to do? Stapedial reflex testing. Okay, and by an impedance audiometry, we are looking the stapedial reflex, and it can be either absent or less than half the amplitude of the opposite side. Okay, this can be either absent or less than half the amplitude of the opposite side. It is taken as abnormal, right? And another one is a chorda tympani. Chorda tympani supplies, one is taste and also submandibular salivary flow, isn't it? So how is taste is tested? By electrogustometry. Okay, electrogustometry is a electrical stimulation of testing of the taste, or it can also physically tested by your salt, sugar, citrate, etc. Right? Then another one is the salivary flow. How will you test the salivary flow? That is, we have to cannulate the submandibular salivary duct and then look for the salivary flow. Right? If it is less than 25% from the opposite side, it is abnormal. And this salivary duct cannulation is time consuming and in high level of expertise is needed. So we can take the salivary pH. Right? And if it is equal to or less than 6.1, that is taken as abnormal. Okay. So these are the Topo diagnostic tests for find out the site of lesion and testing the individual nerve fibers. And if it is supranuclear lesion or if it is at the nuclear level, or if it is at the CP angle level, this can be tested by of cranial nerve and along with the CT and MRI. Okay, so CNS, CT scan and MRI scan. You will get an idea about the site of lesion. And if it is at the internal auditory canal or the meatal segment, along with 7th nerve, there is an 8th nerve also, vestibular as well as the cochlear component. So for vestibular component, you can do an electronystagmogram, and for the cochlear component, you can go for an audiometry, right? And extracranial component is by the facial muscle movements. So this is a topodiagnostic test. At various levels, the site of lesion can be found out by doing this. Okay.